Good afternoon, everyone. Welcome to today's session. This is the KNH UON webinar. We are here on Thursday for the nursing series coordinated by Nursing Standards and Research Department at KNH. Feel most welcome, and we will allow a few more minutes for our friends who are really joining and colleagues to be able to join, and then we can start off. If we give it 2 minutes from now at 2:10, we will start our presentation. So get ready, set, so that we can take off. Thank you.
So notes zitakuwa hapa chini. Sawa.
So yes, we said we will start at 2:10 with the presentation. Again, I say thank you. I see we have joined in large numbers, and we are ready to take. I want to take this opportunity to introduce the presenter for today's presentation. Today's topic is crying wolf or wolf, depending on your school. Crying wolf, clinical alarm systems in acute care settings and the impact on patient safety at KNH. Now, this presentation is a preliminary presentation of the preliminary findings of a study that is almost being concluded. I believe the presenter will introduce the co-investigators in this study. And our presenter for today is Mr. John Kiragu. Mr. John Kiragu is a senior nursing officer who is working currently at the Accident and Emergency Department, a typical acute care setting in KNH. And he holds a Bachelor of Science in Nursing degree and a Master's in Public Health degree. He will say more about himself and his co-investigators, but we are happy to have him. He is present here and ready to start us off. I just want to say one more thing so that we are comfortable. For the nurses who have joined in this forum, we shall provide CPD points. Just ensure that as you log in, you provide your full details in terms of an email address to which the CPD code can be sent for you to claim the points. I believe the other cadres will also make appropriate arrangements for the CPD codes to be shared appropriately. So now back to the topic. It is quite catchy. And when this was shared in one of the forums for the nurses on Let's Talk Nursing, I could see positive comments concerning the topic. And people say this topic always comes up when it is time for critical care conferences. That shows it's a very important and relevant topic for nursing. And that is why we found it appropriate for this nursing series in today's session. So Mr. John Kiragu, karibu sana, and help unpack this topic that sounds interesting. You have about 1 hour for this presentation, and then we shall allow participants to do a few input or questions at the end of it. Karibu sana.
Okay, thank you very much, Madam Ruth. And thank you very much, participants, for joining in. And welcome to our presentation today. on crying wolf systems, crying wolf clinical alarm systems in acute care settings. As introduced, John Kirago here. And today I will be presenting this on behalf of my co-authors, Dr. Lady Okutoi and Mr. Joshua Tunga. And let's start off. So our title today is on crying wolf clinical alarm systems. And this title, crying wolf, actually captures the phenomenon that we are about to discuss today. And the phenomenon under study is called alarm fatigue. So, and this is what happens if we have healthcare workers being exposed to clinical alarms that are supposed to alert when, for example, something goes wrong with our patients. So they are supposed to be a substitute for limited human resource. So they are supposed to be a proxy human surveillance. And if they, so ideally they are very important, but if they go off so many times, so frequently, they can become a burden. And when they become a burden, that is when we call it alarm fatigue. So let's dive into this discussion today. So the outline of the presentation will cover 6 main areas, starting with introduction to alarm fatigue. So I hope by the end of this presentation, I hope to convince you on why you should care about this phenomenon called alarm fatigue. And number 2, we will cover research gaps around this phenomenon. We'll mention some of the theories and conceptual frameworks that have informed our study. And then we will dive into the methods of our study. We'll share the preliminary results. And lastly, we'll talk about implications for practice and future research. Alarm fatigue. So we all know that medical devices and machines have voices, and they have voices in terms of alarms, and those alarms are supposed to protect patients. And like I said, they are a substitute because we have limited human resources. If we didn't have alarm fatigue, you will have a nurse or a doctor by the bedside round the clock. But we have these very important devices just to alert us when something goes wrong, when we as clinicians attend to other important primary tasks. As a nurse, our other primary tasks include drug administration, turning of patients, and you could have, you could be attending to a different patients and leave the other patient just connected on a monitor and rely on that particular monitor to alert you when something goes wrong. So these devices are very important. So clinicians, nurses, and doctors listen and they intervene when an alarm for something wrong goes off. The machines have been designed in such a way that every beep is supposed to be a call to action. But too many false beeps can be a burden. And let's see how too many beeps can be a burden in the next slide. So with proliferation of medical devices for patient monitoring and life support, clinical alarms have become many, louder, and more frequent. But as we are going to see in this presentation, sometimes this is unnecessary when you have too many alarms and too much noise within the unit. And we are also going to see more alarms is not equal to safer care. And when you have too many alarms, we have given an analogy of a crying wolf phenomenon. So these are alarms that are false in nature. They keep alerting clinicians to attend to patients unnecessarily. So clinicians get used to false alarms, and they develop something called a mistrust to the clinical alarms. And with time, they stop responding to these alarms because they start viewing them like crying wolf alarm systems, because they know even if the alarms are going off, these are just nuisance or unnecessary alarms distracting them from their primary tasks, other primary tasks. And this table here shows the typology of alarm systems within our hospital. There are different types of alarm systems. And as you can see, we have two main groups, the clinical alarms and the technical alarms. Under clinical alarms, you have the true, the false, and the nuisance. So from literature, we found out that most of our alarm systems that contribute to these crying wolf systems are either false or nuisance alarms. Ideally, these are the ones that contribute to the alarm fatigue problem. On the other side, we have technical alarms. And under technical alarms, we have the true ones, which are very critical. And then we have the false and the avoidable. To take you back, the definition of a clinical alarm, this is an alarm that warrants a clinical intervention for the patient. And a technical alarm is that it's an alarm that warrants a device check if a device has malfunctioned. So from literature, most of our clinical alarms contributing to alarm fatigue problem are false clinical, nuisance clinical, avoidable technical, or false technical. We have only about 5 to 20% true clinical or true technical alarms. And these are the number of alarms here. So now, how do these excessive alarms lead to patient harm? So this diagram here shows the link between how sensory overload from excessive amount of alarms, when clinicians work within such settings, they start becoming insensitive because of this sensory overload. And then they end up becoming unresponsive to alarms. This reduces their competency, because competency in terms of alarm management will be timely response and appropriate response to clinical alarm. So even if you have an alarm that says asystole, nurses will not care, or doctors will not care, because they've been used to so many false alarms. And now this becomes an issue. So at the end of the day, our clinicians start missing critical alarms that could warrant a life-saving intervention. So this is how alarm fatigue leads to patient harm. Under this slide, I wanted to show you why, when we are dealing with this alarm fatigue issue, it is not enough to fix clinician issues. It is very important to go beyond the clinician and start addressing other underlying issues that could contribute to patient harm from alarm fatigue. And that's why under this slide, we have three main categories of issues related to alarm fatigue. Number one is technology. For example, the type of device, the sensitivity of the device, and the visual and audio signals. So the design of most of our devices, for example, the mechanical ventilators, even the cardiac monitors, they have been made to be very, very sensitive to changes in any changes in patient parameters. So this oversensitivity, sometimes it can pick false alarms. It can even pick something like when the patient is being turned, or when the patient sits up to eat. So that would be an alarm. So the technology has been designed in such a way that it's safer to alert the nurse just to check on the patient than just to keep quiet and not say anything about it. So most of our machines are extremely oversensitive to any slight changes in patient parameters. The second main issue about alarm fatigue is about personal characteristics. So age and also cadre and even the unit, the specialties, these have been shown to contribute to alarm fatigue issue. Because, for example, if you have untrained clinicians about alarm management, they are likely to be exposed to unnecessary alarms within the unit. But if you have more, clinicians with more knowledge about alarm management systems, they are likely to effect appropriate alarm settings to reduce unnecessary exposure. The other issues are about user issues. It's about training, education, and the level of burnout. And then systems. Systems have a very big impact on alarm fatigue. We are going to see literature emphasizing the role of alarm management protocols. In some studies, institutions without alarm management protocols have been shown to have high levels of alarm systems, high levels of alarm fatigue, sorry. And then systems or organizations that have a very high workload, and this workload include alarm management system, maybe nurses or doctors are understaffed, and they have very many other primary tasks apart from managing alarm systems. So those ones have been shown also to increase the risk of having alarm fatigue, as well as working conditions. Alarm fatigue, it's not just a technical issue or a psychological issue. Alarm fatigue, it's a matter of life and death. As a matter of fact, sometime back in 2013, the Joint Commission in America raised a red flag about alarm fatigue phenomenon. And as you can see, they published a report that mentioned 98 alarm-related events between January 2009 and June 2012. And of the 98 reported alarm events, 80 of them resulted in death. 13 resulted in permanent loss in function, and 5 in unexpected additional care and extended stay. They went ahead to establish the main causes of these sentinel events related to alarm systems. And one of them was the alarm fatigue issue. It was the most contributing factor. So they didn't just raise a flag, they called it out as a top patient safety concern. That when alarms cry wolf too often, clinicians stop listening and patients pay the price. But what does literature say? Let's see some of the studies that have looked at this issue. For example, we have a study by Brice and Dunn, and they established a link between something called workload. They established the link between an increase in workload and a deterioration in alarm task performance, and deterioration in alarm task performance here. And then we have two Korean studies here that did establish the burden of alarm fatigue. So the first study here, you can see, it established the alarm fatigue problem to be at around 68%. That is 24 out of 35. Another Korean study as well established the burden of alarm fatigue to be at 65% here. So so a figure like 65% alarm fatigue, that means that 65% of clinicians within those hospitals were suffering from alarm fatigue. And that had an impact on patient safety. A few more studies. One more study here from Ghana by Nyarko et al. So they observed that alarm fatigue was positively associated with two dimensions of burnout: emotional exhaustion and depersonalization. And they concluded that critical care nurses in Ghana experienced high levels of alarm fatigue, which was being affected by multiple factors, including burnout. So sometime back in 2017, 2015, we had a study that was carried out in Kenyatta National Hospital by Megani. And they did this study in the ICUs, and they found out that the majority of nurses within KNH ICUs reported that they responded to alarms of all durations, but do not fill alarm checklists. And neither alarm checklists nor protocols are provided within Kenyatta National Hospital. From these findings, there was a statistical significance between the age and whether the respondents assessed the cause of the alarm beeping. And they concluded that nurses in the unit carry out standard nursing interventions on clinical alarms and response to alarms of all duration, but do not fill alarm checklists. And they recommended that alarm protocols should be developed in the hospital. Now, based on this literature review, so this informed our research gap. It informed our research gap because Megani and colleagues didn't include accident and emergency. So that was one. And they also didn't include medical doctors or physicians. And that's why we decided to carry out a study to address that gap, just to improve on what they did. Number two, they didn't establish the burden of alarm fatigue within Kenyatta National Hospital. So we went ahead to design a study that would quantify from a scale of 0 to 100% what was actually the burden of alarm fatigue within the hospital. Like I mentioned, so that literature review informed our research gap, the purpose and the rationale of the study. And I mentioned about the study design. The previous study did not include doctors and doctors' cadre, and it did not quantify alarm load. Knowledge gap, alarm burden on alarm fatigue not known in our setting. And then data gap, limited, actually non-existent alarm data system within our hospital. So it was very, very important to carry out this study. Our study, our conceptual understanding was informed by two main frameworks. First, it was informed by Lazarus and folklore theory. the transactional model for stress and coping mechanisms. It was also informed by the conceptual framework on causes of alarm fatigue by Debs and Claudio 2015. Specifically, the transactional model of stress and coping mechanisms by Lazarus and Folkman defines stress as a mismatch between demand to solve a problem and the capacity to do so. The theory goes ahead to explain how stress becomes a psychological problem. It explains that when individuals face a stressful situation, they start with a cognitive appraisal, the primary appraisal, which includes recognition of the stressor, making a judgment about the stressor, whether it is excessive, whether it's something they can manage, whether it's something they can look resources to address, whether it's important, whether it's urgent. So that's a very basic level of reasoning that normally happens every time an individual encounters a stressful situation. In this case, we found this theory to be very appropriate because alarms can be significant stressors within our clinical environment. Then after recognition of the stressor, the individual goes ahead to evaluate resources and the capacity to address the stressor. For example, if they have recognized overwhelming number of alarms, they resort to leveraging on, for example, their knowledge, their personal skills to address the issue. So this level determines the coping mechanisms they will adopt. For example, if they can't do anything about the stressor, such as the alarm systems, so they are likely to ignore, they can silence them, they can identify the source of the alarm. We desire that they attend to the patient or address the alarm issues. But if they don't have the capacity, they will adopt not so good, healthy coping mechanisms, such as ignoring some of the alarm systems or even silencing them. Yet some of these alarms are supposed to communicate something. And the second conceptual framework that informed our study came from Deb and Claudio 2015. And you can see Deb and Claudio recognized the role of working conditions and the staff individuality as a primary exposure or a primary predictor of alarm fatigue. And they went ahead to measure now the effect of alarm fatigue and staff performance. Now, based on those two theories, we came up with a conceptual framework about what we thought would be fit for this context. So we hypothesized that knowledge and attitudes on alarm safety would predict alarm fatigue. We also hypothesized that burnout would also contribute to alarm fatigue, but this would have a bidirectional nature because alarm fatigue could contribute to burnout as well. So this, from previous literature, these two are highly, they have a very close association. And then we hypothesize that the amount of workload, whether it's alarm management workload or other primary tasks, it would also predict alarm fatigue. But we also hypothesize that if you have an alarm fatigue, you might also perceive to be having a higher workload. So this would also have a bidirectional nature. And then we also hypothesized that an organization or a departmental patient safety culture, the way departments do things, their priorities, whether they prioritize quality, whether they prioritize quantity. We hypothesized that this would have an impact on alarm fatigue. Equally, staff characteristics and even practice, we hypothesized they would have an impact as predictors on alarm fatigue. Now, based on this study, within this study, alarm fatigue was defined by based on a 9-item criteria by Wooderich et al. 2023, who published this 9-item criteria to be, a very, very useful and reliable tool for measuring alarm fatigue. And this tool would have the stressors, the stress indicators, and even the coping indicators. For example, the first question on whether with too many alarms on my ward, my work performance and motivation decreases. So this will be on the stress scale. And then an example of an item on a coping scale, it's item number 4, that states that responsible personnel respond quickly and appropriately to alarm. So this is the tool we use to define alarm fatigue and even to measure alarm fatigue within our study. So onto the methodology. So this study, Ruth mentioned that we are sharing preliminary findings of the study because we are not yet done with the full study. We designed 2 approaches to address this issue. So the first arm of the study, which we are discussing today, was a survey design, a cross-sectional survey design. And the second part of the study was the non-participant observational design. So so today we are sharing the first arm of the study, the cross-sectional design. And the study setting was accident and emergency, pediatric ICU, and main ICU at KNH. So this study was approved by KNH UON ERC, and that is the approval number. And the study tools, we used the Bloom's cutoff to assess the level of knowledge and practice. And then we used MASLAC, burnout inventory tool. This is a 3-dimensional burnout assessment tool measuring emotional exhaustion, depersonalization, personal accomplishment, as previously used in literature. Then I mentioned we used the Wooderich 9-item criteria for alarm fatigue. We used patient safety culture questionnaire adopted from 2 Korean studies. So, and this is the 5-item criteria measuring leadership, teamwork, patient safety, knowledge, attitude, patient safety policy procedures, non-punishment environment, patient safety improvement systems, and even patient safety priority. So the 35-item criteria was amounting to around 110 in total and a minimum of 40. So if the patient safety culture score was coming to 100%, so that was a department that was very keen on safety. If the department had 0%, so that was a very unsafe department to have your patient. And then we measured perceived workload across 4 dimensions using the NASA TLX, task load index tool as applied by Tubes, Cole et al. 2018. So the tool was based on literature, based on the few items I've mentioned in the previous slide. So the tool was administered through interviews. Data management was done in RedCap software. Study population included all healthcare workers, nurses, and medical doctors working at the study departments at least within 3 months prior to the study. So this was important because we needed to interview people who had real exposure to clinical alarms. So we eliminated students, for example, those who rotated for 1 or 2 weeks, 3 weeks. But this meant that any student, for example, registrars who worked in those clinical acute care settings for the last 3 months was eligible for the study. So sampling was a proportionate sampling across the departments, and it was by simple sampling within departments. And from the sample size of 157 healthcare workers here, the desired 157 healthcare workers, 51 were from accident and emergency, 36 from MICU, main ICU, 13% from PIC. So the questionnaire assessed the level of knowledge, patient safety culture, perceived alarm management workload, burnout, alarm fatigue, and barriers to optimal alarm management. So the analysis applied to approaches, bivariate analysis. And from the bivariate analysis, we used a p-value of less than 0.25 as recommended by Hosmer and Lemeshow to select variables that would go to the multivariable analysis. And model selection was done by backwards stepwise selection. And we determined the adjusted R-squared just to assess the explicative value of the model. All analysis in this study was done in RStudio version 4.4.3 2025. On to our findings. We have the age of the participants, the sex. We had the participants' age we had a median of 36 years. Majority were females at 60%. Majority were nurses at 73%. Majority here had a degree at that 7%. And then professional experience, we had a majority with 6 to 10 years of experience. And then most of them were from A&D comorbidity status. Very few nurses, very few clinicians had issues, maybe comorbid conditions. And terms of service, majority were on permanent and pensionable basis. And down here, majority self-reported that they have had a training before on alarm management systems at 53%. No, sorry, majority reported that they had not had a training on alarm management systems. In terms of prevalence of alarm fatigue across departments, so this was accident and emergency. That the red bar chart shows the high level of alarm fatigue at a prevalence of 14.3%. So this was at A&D. Comparing this to main ICU, main ICU had a high alarm fatigue level was only 5.9%. PICU was at 10%. And this goes to show, I mean, we probably have an issue with accident and emergency in terms of alarm fatigue levels. In terms of safety culture, our findings, our data showed that the 3 departments are pretty safe departments to have your patients. And because you can see from 0 to 100%, they were all ranging at around 70% level of patient safety culture. So there wasn't much difference across the 3 departments in terms of patient safety culture. In terms of prevalence of burnout, the dimension of emotional exhaustion showed that the study population were experiencing high levels of emotional exhaustion, a high of 32%. So that 2% of the participants were experiencing a very high level of emotional exhaustion. And 48% were having moderate levels of emotional exhaustion. In terms of the second dimension of burnout, depersonalization. And depersonalization, this is an issue to do with detachment. When clinicians start treating patients or even their colleagues inhumanely. So, and that's a feature of burnout. So you can see that we had 10.2% of the study population being completely detached from their patients or even from their clinical environment. 10.2% level of detachment. And this is of concern. In terms of the third dimension of burnout on personal achievements, most participants, actually 49%, had a very high level of burnout in terms of personal achievement. And by measuring personal achievement, we ask the participant if they feel they are effective or if they are accomplishing important things in their lives relative to, with regard to their job roles and responsibilities. Most of them were scoring low. High here means low personal achievement at 49%. And this is of concern because of the staff motivation and morale, actually to do what they do in terms of responding to clinical alarms and balancing that with other primary tasks. In terms of knowledge and practice, so this was a very interesting finding that the clinicians were very much aware of what they need to do in terms of clinical alarms management. They knew what to do about optimizing alarm safety. But if you look at the second bar chart, very few people, very few respondents would translate their knowledge into practice. And this is of concern because we need to understand that education about alarm systems is not enough. We need to explore other factors that can drive practice, the right practice, translating what they know into practice. So this slide shows the bivariate analysis on predictors of alarm fatigue. From this table, you can see that categories of age were significant. There were significant predictors of alarm fatigue. Sex was not. CADA, in the bivariate analysis, CADA was a significant predictor of alarm fatigue, with doctors having higher levels of alarm fatigue than nurses based on the bivariate analysis. When we come down to the workload on bivariate analysis, workload was a significant predictor of alarm fatigue, and so was patient safety culture. In addition to that, when we come down the table to the burnout, emotional exhaustion was a significant predictor of burnout. That those clinicians who were experiencing high levels of emotional exhaustion were likely to have high levels of alarm fatigue, unlike depersonalization and personal achievement. Overall, So we adjusted all the other variables using the backward stepwise selection method. We forced them into a model, and we wanted to see if you control every other variable that we studied, which variables would still remain in the model and explain the alarm fatigue phenomenon. Based on the adjusted odds ratios and p-values, age remained a significant predictor of alarm fatigue. So it appeared that clinicians above the age of 45 years were better at handling alarm systems, or they were better at coping with alarm systems, and were less likely, were 52% less likely, 53% less likely to experience alarm fatigue compared to the younger clinicians. In terms of the level of education, it also appeared that those clinicians with a degree compared to those with a basic diploma were also more likely to be exposed to have alarm fatigue than other levels of education. And then in terms of workload remains a significant predictor. As you can see here, so with a percentage increase in workload would translate to a percentage increase in alarm fatigue. And this was statistically significant. Same thing with patient safety culture. The higher the level of safety culture, the lower the level of alarm fatigue. So safety culture was protective. And this supports the ongoing culture change initiatives within the hospital because safety culture involves very many things, starting from quality, the way clinicians communicate, leadership, departmental priorities, and teamwork. So this was a very significant finding. And lastly, only one dimension of burnout remained a significant predictor, and that is depersonalization, being detached. In fact, our findings show that being detached from the clinical environment, from your patients, was protective against alarm fatigue. You can see the p-value, a very strong p-value here. So onto our discussions. Our findings are consistent with previous literature. So we had an overall alarm fatigue at KNH of 50%, and which was slightly higher at accident and emergency. In Ghana, it was reported at 61%. In Korea, it was 68%. Alarm fatigue is significantly associated with the depersonalization dimension of burnout, such that those with high level of depersonalization were less likely to have high alarm fatigue, indicating that clinical patient detachment, a coping defense mechanisms against clinical stressors like alarms, would protect healthcare workers from suffering from alarm fatigue. Conversely, in Ghana, alarm fatigue was positively associated with depersonalization and emotional exhaustion. So this is of concern, and so we probably need further studies because these are now mixed findings on the direction of the association between alarm fatigue and dimensions of burnout. Workload in alarm management tasks and other primary clinicians' tasks are associated with increased alarm fatigue. So we mentioned that a percentage increase in alarm fatigue a percentage increase in our workload would translate to a percentage increase in alarm fatigue. And this was consistent with findings by Claudio on the role of workload in increasing alarm fatigue. Further, the culture of patient safety, we found it to be protective against alarm fatigue. And this was consistent with findings observed in Korean hospital that found that patient safety culture is one of the strongest predictor of safe practices. Older clinicians had lower risk of alarm fatigue compared to the younger clinicians, probably because of their experience, probably because they have better adaptive and coping mechanisms. So this is subject to further studies, just to understand why are our seniors, our older clinicians better at coping with clinical stresses. Lastly, the level of education of healthcare workers, it had an impact on alarm fatigue, especially when you're having a degree. And this could be maybe because those with degrees have higher clinical expectations than those without. So their perception of urgency could be more acute or higher than other levels of education. But this could also could imply the need for us to investigate interaction between level of education of the healthcare worker on the effect of other predictors of alarm fatigue, which we will explore further. Study limitations. One limitation was in the design of our study, the cross-sectional design. So a cross-sectional design would give us a point estimates on alarm fatigue burden, but this could change with time. And so it's not something we can generalize across the organizational calendar. And then the second limitation, it is possible that we had interviewee bias, especially when we ask very sensitive questions around personal accomplishment and even depersonalization. I mean, you could have a situation whereby the respondents were giving positive or favorable responses. And then lastly, the other study limitation, we had missing data. I mentioned these are preliminary results, so we will embark on an approach that addresses the missing data in our study and see if we might have different findings if we apply imputation methods to deal with the missing data. Implications for practice and research. Number one, our study supports the need to explore enablers for practice. We saw that there was very high level of knowledge, but very low levels of practice, For example, our findings support quality improvement interventions on alarm safety practices, workload improvement, burnout alleviation. Number two, our study supports ongoing culture change initiatives to improve safety and staff well-being, including burnout alleviation within clinical workflows and alarm safety. Our findings further support the need to explore smart alarm systems that could have a role in alleviating unnecessary alarm load fatigue and enhancing alarm-related patient safety. Some departments may need targeting or may need targeted interventions to alleviate high levels of burnout and alarm fatigue, such as accident and emergency. So all the acute care settings are not equal. The departments within acute care settings are not equal. They have their structures are different and their clinical workflows are different. So we may need targeted interventions to address burnout and alarm fatigue fit for some of those departments. Lastly, our findings support the need to institute and disseminate evidence-based alarm safety protocols and guidelines in the study settings and similar acute care settings. So first, we actually don't have information on alarms within our hospital. So probably we have an opportunity to establish evidence-based protocols and even a database on alarm systems that could inform alarm fatigue management practices. Our take-home message: too many alarms, frequent alarms, and devices do not equate to safer care. Clinicians are not ignoring alarms because they don't care. They do care. So we need to start to not just focus on fixing clinicians. Let's go ahead and fix systems. Let's go ahead and fix technology. I hope by the end of this presentation, coming to an end in a few, I have convinced you that alarm fatigue is a public health and a patient safety issue. And there's the need to make healthcare workers more sane and more competent by dealing with alarm fatigue issue. So our study shows opportunities for further study and investments. For example, institutionalization of alarm safety standards on alarm management protocols, developing information on database on alarm load, routine assessment of alarm safety, and further research on strategies for reducing and preventing harm, potential harm or actual harm, and medical errors related to alarm fatigue. Let's optimize alarm stroke device safety. Let's stop normalizing noise in critical and acute care settings, because noise kills, as we have seen from our experiences and even from literature. So we have come to the end of this presentation. I would like to acknowledge my co-authors, Mr. Joshua Tunga and Dr. Lydia Okutoi, and also acknowledge the administrative support, clinical support from Mr. Makori, Mr. Otero, and our DNS, Heri Mukwana, as well as funding support from our medical research department, Dr. Kinovia, and the team, as well as this opportunity by the nursing standards to disseminate findings from this study. So thank you very much. I welcome any questions or need for clarification. Santi.
Thank you so much, John, for this wonderful presentation. Participants, I am happy to just mention that we have about 500 participants in this audience. That's quite encouraging. That means knowledge sharing is quite wide. And today's topic is one of those topics which really empowers us as nurses and clinicians to ensure that we do not kill patients when we intend to actually improve their safety. We spoke through this phenomena of alarm fatigue, and alarms are not meant to become a burden. They're meant to increase patient safety, and that is how it should be. So I think we have had that presentation. We welcome your comments and your questions in the chat box. Let me see whether I have any. I'm not sure I'm seeing any so far, but I appreciate that the participants have given thumbs up from the beginning of the presentation, showing that this was really good. So we are happy to receive your feedback. We will be happy also to hear your questions and your inputs. Thank you. Could we have the questions, comments coming? Okay. So I'll take there are some questions here. Anonymous attendee is asking about having not received CPDs for very many webinars, only 5 points from January. This is well noted. I would wish to know which professional cadre this attendee is. Okay, thank you. So any questions on CPD will be addressed at the end. Let me focus on questions on the topic. Questions on today's topic. Alarm fatigue was the phenomena that has been very well described. Grace Waringa is asking where, as Miku, probably this is to the presenter. I want to interpret it as why is Miku medical ICU not included in this study? That's my interpretation of the question, unless otherwise. Any other? Thank you, Neema Muinde. A good presentation there. I totally agree and concur with you. and the rest of the participants also do. Stephen Michel says, a well thought out research, hoping it will be used to enhance safety for our patients, especially in our ICUs. Yes, Stephen, we can assure you that this is a part of the evidence-based practice initiatives, and therefore the findings of this study will translate to improved care in our ICUs. And I know Mr. Kiragu will have comments on the same. And if, I don't know whether any of his co-investigators are also present, we would love to hear from all of them. Again, Rogers Were says this was wonderful. So allow me pass this to Mr. Kiragu to just respond to that one question. What about medical ICU?
Okay. Can they hear me? Yes. Okay. That was, I mean, a very good question. So Miku here stood for main ICU. So in KNH, we have main ICU and the medical ICU. So main ICU is surgical. So so I think it's was it Stephen who pointed that out?
No, that was Grace Waringa.
Chris Waringa.
Yes.
Okay. Now we selected study departments purposively. So we needed departments we could manage within the study budget. So we could not manage to study alarm fatigue across all the departments. Actually, KNH has even an ICU in the private wing section. We have an ICU in OBS-GYN ICU. We have even four, are they four? Five? Yeah. We have different types of ICU in KNH. So we needed to only have a sample of ICUs in KNH. So we picked up on main ICU. So we picked up from PICU just to present, to have pediatric representation. And then we didn't needed to include accident and emergency because previously alarm fatigue issue and even alarm management systems had not been studied well within accident and emergency, because our accident and emergency sort of have rooms that provide critical care services. So we needed to have a feel of the same. So, like I said, because of budgetary constraints, we could not study all ICUs. But based on our study findings, we feel that we are confident that these findings could be very, very useful in enhancing safety in all other ICUs within KNH, because we, as much as these departments are different, they have cross-cutting challenges and they have cross-cutting issues. So they could benefit from these findings. Thank you very much for that question.
Okay, I think very clearly answered. James Gaduki has an interesting question, and I think I'll leave this to the research department to respond. We are here with Mr. Nelson. He will respond. He's a student who is asking about some research, how to go about conducting data collection in KNH. So that will be answered later. Then the other question from one of us anonymously is, apart from the machine noises, could the same phenomena be extrapolated to staff who call the doctor, even without having a good assessment of the client in question, even in non-critical care settings, such as maternities? Because some staff can drive you nuts, interesting, with complete patient details. So I was relating to the lack of trust and fatigue as soon as one sees their call. That is his perception, his or her perception. So keep some comments coming, John, as I read probably one more question. Can the volumes of those alarms be at acceptable levels? They are usually too loud. I think this the presenter mentioned. He will again clarify. How about we take those two, then we continue with the other questions, John?
Thank you. Good question. Good question. I think by Anonymous.
Yes.
Yeah. Let me start with this one. Can the volumes of those alarms be at acceptable levels? And they are usually too loud. Yeah. So within this survey, we didn't and probably this is one of the another study limitation. We didn't survey the biomedical technicians who are very critical in helping us fine tune and even customize or even address technical issues around the machines. So this is an opportunity for us to sit together. So within the alarm safety management committee or such a platform. So we need the participation of biomedical technicians and engineers who will help us to understand the noise levels of the machines, the calibration, and the rest. Because nurses and doctors, the clinicians work hand in hand with the biomedical engineers just to fine tune the machine. Because when machines are having technical challenges, such as when the noise is too much, it's the biomedical engineers who will come in and help us, for example, calibrate the machines the right way if the nurses or the clinicians are not in a position to do that. So my comment about this question is that the working hand in hand with the biomedical team would be very, very important just to know, just to evaluate if we are having too much of the noise or see how we can recalibrate the machines so that we don't have overexposure to clinical alarms. Yeah, thank you. And then there's the other question. I'm not sure. I don't understand the question. I don't know, Ruth, if you understand the question.
Which one?
That apart from the machines, could the same phenomenon be extrapolated?
Oh yes,
to
this
staff?
is a participant who is concerned that staff would simply be making the person get fatigued, because the moment the person sees their call, the person anticipates that they are calling without due assessment of the patient and the need for the call.
Okay.
So the person is already feeling fatigued because of just the sight of that call.
Okay, being
Yes.
called mentally
Yes.
patient. Oh, okay.
So where the call is an equivalent of an alarm.
Okay.
But a false alarm, could
Yes,
it be
yes,
a
yes.
false alarm?
Yes.
The way you categorize them.
Oh yeah,
Very interesting.
No, that's I now understand the question. Thanks, Ruth. Yeah, so like we said, alarm systems are a substitute because of limited human resources. They are a substitute because you can't have a nurse or a doctor by the bedside around the clock. So on one side, we can have machines, device, as alarm systems just to alert clinicians when something goes wrong. On the other hand, you can have cadres like nurses who spend most of their time with patients and they can alert. They are actually supposed to alert doctors when something goes wrong or something that needs a senior medical review or intervention is needed. So we can view them the same way that number one, we have user issues. You could have that particular nurse calling you because that is much they can do. They have recognized an issue, so they'll have to call you, for example, if you're a senior medical doctor or a senior nursing officer. So that's a user issue. So training might help them to collect more data or conduct proper medical evaluation so that when they are calling you, they are calling you necessarily. But also there are other issues around devices, and we talked about technology, and also there are other systems issues that could warrant, for example, one clinician calling another to come and help review a patient. And that could be issues around staffing. So that could be around issues around protocols policies around alarm management, protocols around standards of care, quality of care. So we can't just look at the user. So I think my take home today is that whether we're talking about alarm fatigue from devices or even alarm fatigue from intercadre consultations, clinicians calling one another, let's have a holistic view of this issue. So let's address the user, empower them with education, and create an enabling environment for the right practice. But let's go ahead and address and fix technology issues and even system issues such as staffing and workload and very busy clinical workflows. Yeah.
Thank you, John, for that elaborate answer. I want to put in, I think, some observation also. From this question of the clinicians or other team members calling and giving incomprehensive assessment to the person they're calling, I want to say therein is a call for us as nurses to conduct comprehensive assessment. And we have the S-bar approach to communication. I think a few months ago, and in the last 1 year, we've been emphasizing utilization of the S-bar communication, whereby you assess the situation, you do some background information, then you come up with your assessment data that is comprehensive but precise, and then now you can give your recommendation so that in that communication, in that call, you're giving a full scenario and actually what you think is happening and recommendations, and the communication is more effective if you use that kind of approach. So yes, you can apply this alarm fatigue in every aspect, but it is a real problem that is very important. And as we have clearly heard, it's a proxy for human surveillance and it needs to be utilized well. Let's go on with the other questions. In our anonymous attendee, in our general ward setups in public institutions, where there are no alarms put up, have you considered the physical calls for care and attention by the patients? How do you quantify the alarm fatigue among staff in such facilities? John, I think this is a case of another human alarm.
Yeah, human alarm.
We'll talk about it. Let's see the other question. How long does, this is Rebecca Mushiri, how long does the webinar take to be updated? This is technical. I'll allow Nelson to look at it. Emmanuel Dosi says the presenter mentioned that in the study, detachment, depersonalization was protective to the patient. How can you explain this finding?
Yeah.
He has had that. And a final question, well, this is a comment, a very insightful presentation, and we can't agree more. Truly, it's insightful. So, John, you have I think two questions before we wind up.
All right. Allow me to start with Emmanuel Dossi. Thank you very much for your question, Emmanuel. So the question is, okay, I mentioned that in the study department, detachment, depersonalization, it was protective to patients. How can you explain this? So our finding was that depersonalization was protective to alarm fatigue. Depersonalization, those healthcare workers who are detached from patients, and by detachment, I mean those who didn't have empathy. And this is a dimension of burnout, depersonalization. It's one dimension of burnout. So if your sense of apathy diminishes, you become inhuman, for example, and detached to patients. You become detached even to clinical care. You become detached even to your colleagues. So our findings were that behavior or that dimension of alarm fatigue was protective to alarm fatigue. Yeah, so it makes sense because if you are completely detached from your patients, so your sense of urgency and your perception for urgency has been blunted. So you don't see urgency, even if your alarm it's clearly indicating an asystole or an atrial fibrillation or an SVT, supraventricular tachycardia. So if you don't see that urgency, so you won't put in the effort to run around and address the issue. And that's why this is protective to this particular person, not in a very good way. It's protecting to them because they don't care about what is happening in the clinical environment. So they are just there. And this is of concern that if you have high levels of burnout, you'll have clinicians come to work, clock in, and clock out when time is up, but they will not have had an impact on your patient because they will not be empathetic. So while this is protective to them as people, it can harm the patient. Yeah. I hope that is well answered.
Very clear,
Yeah.
and thank you, John, for that clarification. I think we have taken all the questions and we have appreciated all the comments. As we mentioned earlier, this is just part one of an ongoing study. We shall be back. John and the team will be back with part two of their findings. And they have challenged us with the areas for further study, a whole list of them. Feel free to also delve deeper into this topic as we find solutions to and understand this particular phenomenon of the crying wolf, where in English it simply meant a call for help when it is not needed.
Sure.
But
sure.
in this case, the alarm is a needed cry for help, and therefore every alarm call should be one that should be responded to, and that is what we endeavor to do to achieve patient safety. I wish to say that we have come to the end of today's presentation, unless there is any other question I have not seen on the page. Allow me at this earliest opportunity. Yes, John, you have something to say? Go ahead.
You could check if Robert McCoy is around. He might want to
Okay, he's asking me to
Or-
check whether very key stakeholders in this whole process are present in the forum. Any of the core investigators, Dr. Okutoi, Mr. Atunga,
or Mr. McCoy.
any of them who is present could just go in. I think you've all heard our voice. I'm not sure who else is in. This is quite a large number, 500 of us plus. Mr. Robert Makori, the Senior Principal Nursing Officer, Medicine, if you're present. The DNS office, if present or represented here, Madam Rahel. Yes, so, well, I know he has a special place for all of you who have been supportive to this particular study in every way, including the research and programs team. Thank you, team, for finding time to come and share this wonderful knowledge. Yes. And I wish to remind us that we continue to run the nursing series for purposes of knowledge sharing for improvement of patient care. And today's topic took a new twist. It was, yes, patient care, but patient safety was the real thing here. And therefore, we want to invite all of you, the nurses and friends and colleagues, especially if you have content that is going to improve practice in nursing practice, you are welcome to share with us. We run this every first and last Thursday of the month on this particular forum, which we really appreciate for having a chance to use to disseminate knowledge that is that is coming our way. So I think that marks the end of today's presentation. Behind the scenes are key people in this particular presentation. John has already acknowledged many of them, but I wish to mention one of them who may not have been very vocal in this process, Mr. Franklin Barine, the nursing officer in charge of coordination of CPD for nurses. And he's very much available to support and promote CPD processes for nurses. So thank you, Frank, for the work that you're doing under the leadership of Mr. Koisok and the rest of the team members who may not be physically here but are present. I know Mugi, Elizabeth, and Sally are also present, and the entire team. Thank you very much. And without Nelson, I don't know what we will do. Nelson, do you have something to say?
Just to address the CPD queries.
Okay, Nelson is here to talk about the CPD queries. There are quite a number of them. Go ahead.
As, for the CPDs, kindly note that in your reminder emails, each email notification you get for CPD, there's an update down there on your CPD according to the cadres that you belong to. Just to add, we've added nutritionists, that's KNDI, and we've also added lab technologists and lab technicians, that's KMLTTB. And for any question regarding those CPD cadres, you could email knhresearch@gmail.com. PPB, we have sent the attendance list to the pharmacy directorate in the hospital, and they should have or rather you should be receiving points on your portal. You should just visit the portal and check on the previous events. You should have received points for the events you attended to according to the CPD guidelines stated in our emails and also the communications that we do make. If you have further questions on CPD, kindly reach out to us via the email. Also, please make sure that you have fulfilled all the CPD guidelines before doing this so that it will be easier for us to assist you. And with that, we appreciate you attending this session. Our next session will be next week on Tuesday, and you'll receive notifications on this through your email addresses and on our other platforms. Thank you.
Okay, thank you all.